we do have now antibody-drug conjugate, inotuzumab, the BiTE, blinatumomab, and the CAR T cells. And the main question is how to use these three new approaches. What should be the first to be used in a clinical setting? Can we use one and then after the other? Because they are targeting sometimes the same antigen. So it's difficult to come with another drug targeting the same antigen after failure of a drug like that. So at the present time, we do not have the answer. And I guess the speaker will focus for CAR T cell. The question is in the relapsed refractory setting, how CAR T cell can be used to induce a new remission and even to prolong the second remission or further remission and allow us to not transplant the patient. So the balance between CAR T cell and transplantation is important in that setting, especially after a relapse of the disease. And for the bispecific, the main issue is how to introduce bispecific into frontline treatment in order to reduce the relapse incidence. But at the present time is done mostly in patients with higher risk of relapse, who were these patients eligible for stem cell transplantation. So the bispecific is used at the present time mostly to bridge high-risk patients to transplantation in a better condition without using intensive chemotherapy and with a better effect on the disease, allowing us to transplant a patient with a lower minimal residual disease level. So blinatumomab is most used as that. I mean, bridge a patient to transplantation. And the next issue will be, should we continue to transplant the patient after blinatumomab? So that's another important question for the next future. There are still some studies running with combination of, I mentioned blinatumomab plus tyrosine kinase inhibitors, so two new drugs. There are some studies combining blinatumomab and inotuzumab sequentially, which is also very interesting. And blinatumomab and CAR T, the main issue is if we use blinatumomab, which is directed against the CD19 antigen, some relapse after blinatumomab are associated with a loss of the target. So there is no more CD19 expression on the cell surface of the blast. So this is an issue when you want to continue a treatment targeted to the same antigen. So the sequential administration of blinatumomab plus CAR T cell is questionable. It could be efficient in some patients, but it could not be efficient in some others. And actually, in the first CAR T cell trial with Kymriah, blinatumomab exposure prior to CAR T cell was an exclusion criteria.